you're yourself a doctor.
Yes.
Tell me about what kind of doctor are you, and
I'm originally a board-certified pathologist, but for the past 15 years I've practiced emergency medicine.
so you understand all the details of what's going on with you very well.
Mhm.
So tell me, what happened? What was the situation before you and I met?
I just accidentally fell, and I fell straight down,
Mm-hmm.
typical axial load. I walked on it for probably 3-4 days.
Oh, even longer. I would say about, yeah,
Thinking it was a bruise or
Mm-hmm.
a pulled muscle or something, and then I realized this was
It's
going
more
on
than
too
that,
long.
yeah.
And so that's when
And I remember I saw you first. We said we are going to get some films, and we did get those films. So your problem wasn't the bruise. Do you remember what the problem was? What was the problem?
L2 crushed and
Yeah.
displaced. And,
You had a very complex L2 compression fracture with part of the bone, what we call extruded from the bone area, intruded into the spinal canal. So you had a severe stenosis,
Yeah.
severe disc disease, obviously above and below the damage, and spinal, instability actually.
Right.
I remember that as soon as we saw the pictures, I put you in a brace right away,
Yeah.
and we started the process to stabilize you. But how were you clinically doing? I remember you were losing function pretty rapidly just
Well,
in that
you
time
know,
frame.
I had some weakness, and not to embarrass anybody, some
Mhm.
urgency.
Yeah, no, this is a medical situation,
Right.
yeah. So we cannot
And,
openly talk about it.
Other than that, and then I couldn't really walk very well.
Yeah, so walking was difficult, you were having progressive weakness, and these are, as you know, all alarm sign of
exactly.
impending kind of complete neurological damage.
Yeah.
And in all classification, the rapid progressive loss of function.
And it was
is a-
getting progressively pretty
Yeah.
steady.
Now, we got the medical clearance as good as we could, and that was my goal, to get a rapid, good medical clearance. But you have some other medical problems. Tell me about what were those medical problems that we have to deal with?
Well, it's no secret. I've got chronic liver disease, had it
Mhm.
since diagnosed in 1980.
Okay.
Never been symptomatic. I've seen a couple gastroenterologists.
Mhm.
Tests are all been negative.
A consequence of the liver disease is coagulopathy, meaning our blood
Yeah,
doesn't
exactly.
coagulate as well.
Exactly.
And we,
And
go ahead.
that's why my INR was going around 2 or something.
Yeah, actually, it was right before the surgery. We corrected as well as we could. It was 1.6, and your platelets counts was very low. It
Mhm.
was 45,000, and obviously that is a significant medical situation that we like for the blood, coagulopathy be corrected, and for the INR to be normal, and for the platelets to be at least about 100,000 before we do any kind of surgery. But we
Yeah.
were losing function. We were in that situation. We have to see, do we wait and just accept that you are going to have permanent deficit, or should we do a surgery and put you at the significant risk
No,
of
I was willing to
bleeding?
take the risk.
Yeah, and you were losing function. You wanted to take the risk, but open surgery, I don't believe any reasonable surgeon would have offered you open
Mhm.
spine surgery. That wouldn't be just taking the risk. That is like literally bleeding out
Yeah.
in the ward, because
I've seen that kind
Yeah.
of surgery.
and if you want to quickly look at here, you have the complex L2 fracture. Part of it was going out. In an open old-fashioned surgery, we would take the bad disc out, bad bone out. We call it a corpectomy. Even in the best of situation, with the best of medical status, doing a corpectomy by itself is somewhere between 1 and 2 liter, 1,000 to 2,000 cc of blood loss.
Okay.
In your situation with your low
Oh my
platelets
gosh.
counts and with the coagulopathy, we are talking about somewhere significant, like you're replacing your blood in your body 2 or 3 times.
Right.
If in your situation we would have done, that is it.
And probably 6 weeks before I saw you,
Mm-hmm.
earlier last year, I'd seen an orthopedist in Fargo because I thought, I needed my knees replaced, which I've but he didn't want to do it because low
Same
platelets.
problem,
And,
same problem.
and I was working on an appointment with an oncologist I know in Fargo,
Yeah.
you know, but he was in between clinics. And
Yeah, and you know, we surgeons are reasonable, we doctors are reasonable, we weigh risk versus benefit. And for a long time, in your situation that you had, it was, do we put you at the risk of dying, bleeding out in the surgery, or accept that you're going to be paralyzed? And almost every surgeon, reasonable surgeon or anesthesiologist say, okay, being paralyzed is better than bleeding out on the table. And so you had no option with their open surgery. And you know, and the anesthesiologist that they came in and talked to you as well
Right.
about that. You remember what
I
he
sure
talked
do.
about?
I
So
don't
tell
remember
me, what
his
did
name,
he is a reasonable person,
Yeah.
but he's used to open surgery. He knows only open spine surgery. What did he tell you? What do you remember?
Well, he was reticent because of the low platelets and
Yeah.
high.
He said he's not going to do the surgery
The end, yeah.
No, he,
because you will bleed out, you'll die of that surgery.
but then at the end he said, well, you know, as long as I have informed consent, you know.
But the idea was that he and I, we talked, and we said, listen, I understand where he comes from, but my usual blood loss for a 4-level fusion, that's what you got, is usually 150 cc, and if we quadruple that even, your blood loss would be about 600 cc, which is totally acceptable in any situation.
Yeah.
And guess what? Our blood loss was 620 cc, exactly what we expected. Your surgery was literally, we did it under about 1.5 hours.
Oh,
And
okay.
that was sort of different situation
Yeah.
than doing open old-fashioned surgery, which is an 8-hour surgery and twice or 3 times replacing your body blood.
Oh,
So for the first time, we have an option in a
Yeah.
situation like yours, where we didn't have any option in a situation.
No.
Obviously, for even people who don't have your situation, you know, it's better to lose less blood and faster surgery. But in your situation, the open surgery wasn't even an option, and we gave you an option. And I had to really fight to get your surgery done because
Oh,
you know,
yeah,
I had to
remember.
convince them that, you know, with our surgery, with our OLLIF procedure, this is a reasonable, this is a doable process. And tell me, how have you been doing since the surgery?
Real well, you know, I guess if there's anything, I would like to be moving faster, you know, in terms of walking.
But you're walking now,
Yeah.
with some limitation obviously. We are just 4 weeks after the surgery, right?
The PT people say doing fine, you know,
Yeah.
that as expected.
So we are regaining the function back
Yeah.
with the minimal invasive surgery and so on. Now, obviously, you know, the healing is still going to be ongoing. Another things that, you know, that many of my colleagues, neurosurgical colleagues, are going to point out is there is a piece of bone pushing on the spine. You want to do the surgery, right? You should go literally do the corpectomy, drill that bone out, and open up the space, and that is the part that you would be losing a lot of blood.
Yeah.
And I have now a handful of patients in your situation where, because of the age, because of the medical situation, that's not an option. What we have done our what we call indirect decompression and stabilization. And you, among all the other people we have done, is that we really don't have to do that. We don't have to drill on the bone and open up the pores of the bone and cause like gallons of blood loss to get the job done. So
This will absorb.
and one of the signs of adequate decompression is walking, the spinal claudication.
Yep.
The other sign of that it's working is that the leg pain goes away. How is the leg pain?
There's none.
Gone.
Gone.
Good. So, and you see, this is again, you know, that's a good sign that I can show to my colleagues as well as to everybody involved that the stabilization and what we call anatomic alignment and decompression is actually enough. We don't have to do that horrendous. And this is a horrendous surgery. We have to cut you from one side of the body to another, literally drill out that broken bone and take it piece by piece out. And that is where most of the blood loss is, and put something in the cage that expands from end plate to end plate. Obviously, that remains, you know, on standard of care. But in certain situations, I don't believe that's really justified. And because the threshold of doing that horrendous surgery is so high, I think most of my colleagues wouldn't really give you the option of the surgery, which is the right thing. But the only difference is that we had another option.
Right.
So, from what you saw him before the surgery and after the surgery, what's your observation?
It's really made a difference. I think both of us can tell, and especially now, you know, the first couple of weeks were a little bit, I think you were a little bit nervous about a lot of it, but now that you're gaining some more confidence and the pain is totally different, and
Yeah.
even things like,
You're at a transfer from
Yeah,
bed to a wheelchair.
yeah, even getting, you know, up and taking a shower and,
And you know what should I tell about that is that what you're describing, how you look like somebody after open surgery after 6 to 9 months after surgery, and we are only 4 weeks after
exactly.
our surgery.
oh no, and now it's really making some good
Yeah.
progress.
I've noticed, especially after the last, well, I've told you after the last week and a half or 2 weeks, that pain has really diminished.
Yeah.
You know, it's hurting now because I've been sitting here for a
Yeah.
while.
But you know, I'm very optimistic. We are going to get most of the function back,
Yeah, I think so.
and obviously, you know that it's going to take time. But I'm pretty happy with you know what we have achieved with this limited, minimal invasive procedure, and I think you know I'm just looking up to get better and better in the next few months and
Good.
regain most of the function actually.
Good. It certainly seems like we're on the right track.
Yeah.
And I think both of us want it to go faster, but
Yeah.
you don't realize how
We're
extensive
both
it.
very
That
impatient.
yeah.
We're both pretty type A,
Yeah.
but
No, the fact is that you know you went home a few days after the surgery.
yeah,
You would be after open surgery. Most likely, you would be still in an acute hospital. Probably, if you had that much of blood loss, as you know, when you lose more than 2,000 cc of blood, you go to certain kind of medical situation that your coagulation doesn't work. You have to give you factors and so on. There's a good chance, and I've done that. You would have been like for half a month or a month in an ICU
exactly.
just after open surgery. So we are just 1 month. You went home, and you know you're coming back after. I think you know
Yeah,
this is pretty good what we have achieved so far.
No,
he's pleased.
Okay,
I'm pleased.
excellent. Well, thank you so much for the interview. Okay,
Thank you.